All right, my darlings. As you recall, we were just discussing in the last lecture a little bit about the heart itself, the different chambers, the valves that we had discussed, the major vessels rolling off. We had two circuits, one going to the lungs, the pulmonary circuit, and one running to the body out of the aorta there, the systemic circuit. We had worked our way through the microscopic anatomy of the muscle cells in the heart, talking about the similarities with cardiac and skeletal muscle and also a few differences. Big ones being those lovely leaky little areas, the SA node, the AV node, and the less leaky Purkinje fibers that allow for our heart to beat in a very controlled rhythm so that we have blood flowing in one direction with every heartbeat, either to the pulmonary with the right side of the heart or to the systemic system with the left side of the heart. And I had mentioned we were going to go through all the physiology, each of these components, talking about that electro system throughout your heart, that conducting network that allows for those muscles to contract, gives them signaling. We're going to talk about the heart sounds. We're going to talk about volume in the heart. Obviously, when we contract those ventricles, they are going to lose volume, then fill up again, and then in the next round for a heartbeat, do the same thing, contract systole, diastole relax, and fill up again with volume of blood. There's going to be different pressures going on during this time as well. You can imagine when we squeeze down on the blood in the ventricles, that ventricle pressure is going to go through the roof and open up the valves that it needs to, those semilunar valves, kick that volume out into the aorta and also increasing the pressure then in the aorta. And then it'll fall off as the blood flows down the aorta and through your systemic circuit. Pressure in the atrium are pretty low. A little bit of a squeeze, a little bit of a pressure at the beginning when they actually do contract before we have that huge ventricle contraction. So these are all components we're going to go through, as well as when the valves are open and closed. And you can see how these are all color-coded and tie very nicely as we follow to the visual pictures of the heart and what's actually going on. Are we in contraction? Are we relaxing? Is it an ejection phase for the ventricles? Are we in relaxation again where they'll be able to fill up? These are all different components that we're going to discuss. But first, let's continue on with the electrical conducting network there in the heart and how we measure that using an electrocardiogram. So this is a graph of the heart's electrical system. What's going on when it's flipping that membrane potential. That's what we're measuring. And this gives us an indirect indication of contraction and relaxation, but it's not a direct measurement. All right, electrocardiogram, ECG, formerly known as the EKG, probably some other language, I'm guessing German. Let me know if you find out. But this is basically one full heart cycle, and it's a composite of all the action potentials, all that electrical work that's generated by the contraction and relaxation at any given time. As we follow that along the bottom there, where is my arrow? There we go. Time along the bottom here. And then this will be depolarizations and repolarizations. So flipping of the membrane is going to show a difference on this scale here, okay, rolling left to right. There are three waves. We have the P wave. I love how my arrow disappears on me. We have the P wave here. That is indicative of the atrium depolarizing, and when they depolarize, they are going to contract. They depolarize because of that wonderful SA node, those leaky cells that have channels that leak sodium in, make them reach threshold without the nervous system having to signal contraction to occur. They hit threshold and bam, we relay that through those gap junctions and the atrium will contract. Atrial depolarization. Shazam. That signal That depolarization then reaches our next node, the atrioventricular node, AV node, which is then going to reach threshold as well and relay that system through the bundle here to the bundle branches, left and right, down into the terminating ends, those Purkinje fibers. Okay, so that is our QRS complex here, is the ventricle depolarization that you see. And actually at the same time, because it's built in time, the atrium are going to be relaxing or going into diastole during that time period. So we lose that little peak that you would see from those depolarizing here and repolarizing in the huge ventricle depolarization peak, because there's so much tissue here, so many more cells contracting, we're going to have a big peak there. The last wave is our T wave. So if the ventricles contract, they have to relax and they repolarize and go into diastole, opening up and allowing for more blood to flow in. When you are reading one of these graphs, you will look at these peaks, make sure they're there so you have no atrial contraction, your ventricular, and repolarization, and then we're going to redo it all over again. But we also measure time frame between certain letters, as you can see here, PR, ST, QT, and these are very important because the timing of the heart beating as well is also relevant to heart health. The PR interval, you can see, is the beginning of the atrial excitation, okay, to the beginning of the ventricle excitation. So this in time is going to measure that signal of sinoatrial node kicking off to that atrioventricular node relaying the signal for the ventricle to become excited and start to contract. So we're watching the time frame from there to there. The ST segment is right here, and it's a flat line. And that flat line basically means that there is no depolarization or repolarization happening at that time. It is a flat line. And this is actually where we have the entire ventricle myocardium, so all these muscle cells here in the myocardium, depolarized. And when they're depolarized, that means they're contracted, aka in systole, and they're just holding on in that squeeze for that period of time. And you can see it's not that long, but she's there. Then we have the QT interval, which runs from, guess what? Q to T. So what we're looking at here is the time beginning with the ventricle depolarization, which means they're going to start to contract those ventricles, all the way through holding that squeeze, and then through the component of repolarization and going into the relaxation or diastole. So we're looking at the time frame from contraction to relaxation of the ventricles with that QT interval. And time frame is very important. If we have certain peaks missing, if we have too much time between the peaks, those are all indications of something wrong with the heart. I don't know if anybody can hear my dog snoring. I apologize. Madison is very tired. So let's run through this once more, and it's color-coded with the visuals. This is nice. This is great. It's in your book. Depolarization is in the yellow here, depolarization, and when we see some red, that is going to be where we repolarize, flip that membrane potential back to a start state, and the muscles will contract, or relax, go into diastole. So step one for the sequence here of a heart with our ECG tracing. Number one, atrial depolarization. That's going to be our first step, initiated by that SA node. It's going to reach threshold, and it's going to relay that signal through all those cells, through the gap junctions, to have those atrium contract. Then we do have a little flat line there as well, which means those atria are just in a contraction stage, holding, but it's for a very short, brief period of time. That's where we are going to relay to that AV node, and if you recall, it has a 1/10 of a second delay before it's going to relay that signal down to the ventricles. Relaying signal down to ventricles to start to depolarize, and they're going to contract. That is that QRS peak. And you can see at the same time here we have red repolarization and relaxation diastole of those atrium. Moving on, we have that full-on depolarization complete of both left and right ventricles. They are given a nice squeeze and pushing blood to lungs or to body. And again, they hold that squeeze for just a brief moment in time, and that is why we are flatline. There's no change in electrical polarization of the membrane. Now we are going to start to repolarize. The ventricles will relax and go into diastole, and that repolarization is shown here with the T wave. And what began at the apex for the depolarization and contraction is going to again start at the apex for the repolarization and relaxation and run up through towards the base of the heart. That's your T. Then we will have a moment where everybody's chilling, again, that flat line, and we will go right back to the P wave again. So ventricle repolarization complete, back to the beginning, and we start all over. And we do this from about, I think it's third week of spermies and eggs getting together, about 18 days, 18, 19 days. Your heart's going to start doing this. Heart's beating by then until the day you pass. We had talked about some of these already. This is what your ECG looks like. We were just looking at one beat, but obviously when we record this, we're going to look at them over time to see what happens. Here's a normal sinus rhythm. So we have 1, 2, 3, 4, 5, 6, 7, 8 heartbeats recorded here. And you can see your P, QRS, T, P, QRS, T. You can see everything's nice and evenly spaced. So nice normal sinus rhythm. We talked about junctional rhythm. Right, this is where that SA node is not functional, so we're not getting the P wave. That is correct. You can see that the P wave is missing here. We still have the AV node functional. All right, so it will allow for that QRS, the contraction of the ventricles to push the blood, and then that repolarization of the ventricles. Again, loss of that SA node squeezing the atrium. But the workhorses, the ventricles, are doing their job. You will, however, have a slower heartbeat. That AV node is not as leaky as the SA node, so the beats will be slower. You're going to be at the 40 to 60 beats per minute here as compared to the 75 that the SA node kicks off. All right, this is where we're getting into a point where doctors are going to be watching very carefully because you are not having even ventricular contractions. You're skipping maybe every other beat for your QRS and your ventricle depolarization. This is going to mess with your blood flow through your body. It's going to mess with feeding your cells, right? Messing with your homeostatic balance. So we're going to have to keep an eye on that. And you might need to have, at some point in time, a pacemaker, an artificial pacemaker placed in. And this is, of course, your heart having a hissy fit, the ventricular fibrillation. So this is where ventricles, atrium, they're all firing off in craziness, having a little hissy fit in your chest. And the only way, hopefully, we can reset this system is, again, shock. So charge them paddles, zap the heart. Everything goes into contraction because everybody's reached threshold with that electrical current. Hopefully, when everybody relaxes and goes into diastole, the SA node will take over, all right, and get you back in a normal sinus rhythm. If not, up the dosage. Shock with a little bit more. See if we can get that heart to reset to normal sinus rhythm. That's what you're doing with that shock, that electrical shock. Question time. Predict the nature of an ECG recording when the AV, that atrioventricular node, becomes the pacemaker. What's going to happen here? All right, so if that AV node is going to become the pacemaker, we're going to be losing this guy here. What's going to happen? Would it be normal sinus rhythm still? I think not. The P wave is going to be much larger than normal. Well, if it's not firing off, we're losing her, right? The rhythm's going to be slower. I'd have to agree with that. okay, because the AV node doesn't fire as fast. The T wave would be much smaller than normal. Negatory, because if we're firing off, it's still going to repolarize. So, process of elimination, the rhythm is going to be slower, and that is one of the dysfunctions I showed you earlier, junctional rhythm there. All right. We have worked through quite a bit so far. All the anatomy on the previous lecture. We'd worked through the previous lecture. We'd worked through the cardiac muscle fibers already, how they contract, differences between them and skeletal muscles, the energy requirements. These guys are, what did I say, hungry hippos, where they need a lot of ATP, so they need a lot of oxygen, and they need a lot of mitochondria to make that ATP for them to be beating your entire life a whole bunch. We have covered electrical events. We went through all the electrical wiring in your heart, the leaky components, little cells, collections of cells that allow for autorhythmicity, right, firing off without direct nerve stimulation. We did talk about how the autonomic system, though, can tuck in and have a little touch to speed up or slow down, fight or flight, or rest or digest, depending on what we need. But the heart can beat on its own. We don't need the nervous system to do so. Now, let us play with some heart sounds. Where in here do you think we're going to be hearing lubs and dubs? All right, where do you think those valves are opening? Where do you think they're closing? And remember, that's all done by the push of the blood itself, the flow of the blood. Pressure builds up, opens those one-way doors. When pressure builds up on the other side and slams them shut, it's not going to get through because we want the blood to move in one direction. So let's take a peek at some heart sounds.